this is the organization of the talk today. We're going to go over we're going to be interest. And so with bone, so we start from the external canal, go to the middle ear, look at the ossicle. Now I go in the opposite. I go from the inside out. And that's because MRI is obviously much better at the soft tissues and the nerves, right? So MRI is not very good at the bone, but what we use MRI for is the nerves going into the IAC and the facial nerve. So we go from the inside out when evaluating an MRI of the temporal bone. All right, so just keep that in mind. Today for the talk, we're going to start from the CT. So from the outside, the external ear is composed of the auricle or the pinna. Both parts are lined by basically skin that's reflected inward along the canal, and the EAC curves anteriorly and inferiorly, forming this S shape as it extends medially to the middle ear. You might see at the like bony junction. Okay. At the medial end of the canal, you have the scutum, right, which is a sharp bony spur that is formed by the superior wall of the EAC, and it also forms the lateral wall of the middle ear canal. Medially and inferiorly, that's EAC, and then you have this like crest of bone where the tympanic membrane attaches. Okay, so this is the tympanic sulcus. So when you're looking at a coronal image of the external auditory canal, you want to see this nice sort of S-shaped, curved, smooth contour of the EAC. On sagittal CT images, the canal is like elliptical in shape with very thin cartilage, as you can see here. And more medially, the elliptical shape persists with like the anterior wall, floor, majority of the posterior wall formed by this U-shaped tympanic segment of the temporal bone. The remainder of the posterior wall and the roof are formed by the squamous portion of the temporal bone. Now, there's considerable ambiguity in anatomic descriptions regarding terms like the petrotympanic fissure, tympanosquamous fissure, Glycerian fissure. Regardless of what you call it, the arrow here indicates the junction between the tympanic and squamous portions of the temporal bone along the EAC. So that's a normal fissure, okay? That's a normal junction there. And in kids, it might look like a line or a defect. At birth, the entire tympanic bone is incompletely developed. You have two prominences, one anterior and one posterior to that U-shaped tympanic bone. And those two prominences arise and grow towards each other. The foramen tympanicum, also known as the foramen of Houschka, is an anatomic variation that persists medial to the point of this fusion. In most kids, the foramen tympanicum gradually becomes smaller and smaller and completely closes before the age of 5, but occasionally it persists. When present, it is located just at the anterior inferior aspect of the external auditory canal, posterior medial to the TMJ. So if you see this defect in some tissue protruding through there, that doesn't mean that there's been trauma or that it's eroded. That could just be a normal anatomic variant where it didn't close and you have a herniation of a little bit of the contents of the TMJ. Usually it's fat into the EAC. There's usually distance, but well, not pathologic. All right. The tympanic membrane is at the medial. Has a nice cone of light underneath the umbo. The peripheral fibrocartilaginous ring of the TM incomplete along a small arc of its superior and anterior rim, and small folds from the anterior and posterior margin of this incomplete ring extend along the TM to the malleus to form this triangular or lax portion of the TM, and that's what's the pars flaccida. Okay, so it's kind of lax, it's not as tight as the rest of the TM, and that's why it's called the pars flaccida. The remainder of the TM is very taut, and that's called the pars tensa. So the pars tensa is a much bigger part of the TM, and then you have the pars flaccida up here. Moving on to the mastoid and middle ear, we're going to start with the middle ear first. So the temporal bone, and it's a complex air-filled space that can be divided into three parts. The mesotympanum, or the tympanic cavity proper, which is immediately opposite the tympanic membrane. So essentially, trainee, I didn't realize that there's a very obvious reason for how the epitympanum mesomembrane is it above the tympanic membrane. Mesotympanum is opposite the tympanic membrane. The epitympanum is above the level of the tympanic membrane, and the hypotympanum is below the level of the tympanic membrane. All right. And so if you draw a line, a tympanic segment of the facial nerve canal, which we'll talk about in a minute, that is effectively the line between the epitympanum and it can we're going to talk a little bit more and then sorry, if you draw a line from the tympanic annulus here below that is the hypotympanum. So the hypotympanum really, all right, terms like attic and epitympanic recess, those are kind of the line drawn from the scutum segment of the facial nerve, containing the head of the malleus and the body and short process of the incus. Now, if we talk about the anterior epitympanic recess, that is located just beneath the floor of the middle cranial fossa, lateral to the geniculate turn of the facial nerve, and just superior to a piece of bone called the cochleariform process and entrance to the eustachian tube. So laterally, you have a little small ridge of bone called the cog, which I was a trainee. Dr. Curtin would talk about the cog, and I was like, what the heck is he talking about? I couldn't find it in any of my books. And I finally found it in his textbook. But essentially, that's a bone, which you can see right here, that if you ever come across the term the cog, it's this piece of bone right here that separates the anterior epitympanic recess from the remainder of the epitympanum. And the reason we care about it, like in the anterior epitympanic recess can be just a single air cell, or in this case, as you see in this case, it can be a bunch of little tiny air cells, but you can see it's right next to that geniculate and anterior tympanic segment of the facial nerve. And the reason it's important is because if you have disease processes, most commonly cholesteatoma, if you get cholesteatoma, the cog can be a relative barrier to spread of cholesteatoma from the rest of the epitympanum up here. But if you do have cholesteatoma eroding in here, you're much more likely to have facial nerve involvement. So that's why we care about the cog, because it can sort of be this barrier to spread of cholesteatoma. And if it's eroded and the anterior epitympanic recess is involved, you got to start worrying about the facial nerve a little bit more. All right, this is just a histologic segment of that, okay? So here's the cog here, here's the tensor tympani here, here's the stapes, and so this anterior component here is what we're talking about, this anterior epitympanic recess. All right, as seen in this axial CT image, this is another example where, the anterior epitympanic recess is just one single air cell, and this is the cog here, right? And here is your facial nerve. So you can see if cholesteatoma has eroded from here into here, you're more likely to compromise the facial nerve, all right? As you go a little bit more inferiorly, you start to see what's this piece of bone called the cochleariform process, okay? Dr. Curtin used to say that back in the day when we had oral, when the CAQs, the neuroradiology CAQs in the US, that was a big oral exam that they used to do in person, and he used to say in the head, and it had 3 sections. If you said the word towards cochleariform process in that exam you passed. So, and I was always like, what's this bone? So it's this little piece of bone here. We're at the level of the oval window and the stapes and at the level of the cochlea, and it's called the cochleariform process. And it's where the tensor tympani comes in and then takes a sharp right turn, and the tendon goes towards the malleus. Okay. And that actually at this level forms the floor of that anterior epitympanic recess. You can't see it, but there's a little fold of mucosa that goes from the cochleariform process to the lateral wall over here and forms sort of a floor of that anterior epitympanic recess. Okay. And so the only reason to know about the cochleariform process is that's where you're at the level of the tensor tympani that goes towards the malleus. All right. And it's sort of the border between the epitympanum and mesotympanum as well. All right, so the mesotympanum is located immediately opposite the tympanic membrane, as I said before, between these two lines. It contains the remainder of the ossicles, including the manubrium of the malleus, the long and lenticular processes of the incus, and the stapes. So now let's talk about the ossicles, okay? The ossicular chain is located in the middle ear cavity, and it has three bones, right? The malleus, the incus, and the stapes. The malleus is the largest and the most lateral. The manubrium or handle of the malleus attaches to the tympanic membrane. And as I mentioned before, the most caudal tip or inferior tip is pulled slightly medially towards the middle ear, and that's called the umbo, right? And that's that tip that the ENT can see very well on otoscopy. The head of the malleus articulates with the body of the incus, and the neck of the malleus is a focal narrowing just at the inferior aspect here of the head, and it's the site of attachment for that tensor tympani. The short process of the incus is directed posterolaterally, while the long process is directed inferior, okay? And then it takes a sharp right turn, and you have a little small part of the incus called the lenticular process, and that's actually what articulates with the stapes, okay? The stapes is shaped like a stirrup, and it's the most medial of the ossicles. And the head of the stapes articulates with that lenticular process here, right? And this is what's called the Pochel view, which we'll talk about later, but it kind of nicely lays out the whole ossicular chain. And so you can see here, this is the malleus, the head. This is the long process of the incus. It takes that nice sharp 90-degree turn. There's a little lenticular process, and then this is the stapes going to the oval window, okay? And just below the head of the stapes is the neck, okay? Right below the head, right here, is the neck of the stape, okay? And then you have these two crura that arch anteriorly and posteriorly and attach to the foot plate, which covers the oval window. All right, you can see that here on this axial image. All right, so on axial imaging, it can be difficult to get oriented, but you can use some characteristic appearances of the ossicles as landmarks for the epitympanum and mesotympanum. So if you just remember ice cream cone, two dots, dash, dash, you will always know where you are and which ossicles are present or absent on a particular image. Because once you get used to the normal anatomy, it can be much easier to pick up that you're missing a part of an ossicle, which is important in the evaluation of conductive hearing loss and in patients who have had prior inflammation or cholesteatoma. All right, so visually, the ice cream cone is going to be ice cream cone, two dots, dash, dash, all right, as you go from superior to inferior. All right, so here we're at the level of the epitympanum. You have an ice cream cone, okay, and the head of the malleus and body of the short process is the identified, right? So the head of the malleus is the ice cream, okay, and the apex of the cone points into this little space here called the additus ad antrum, which is the connection between the middle ear cavity and the mastoid, or the additus ad antrum. And it's located in that space is actually called the fossa incutus, but not important. All right, and then when you move a little more inferiorly, the ossicles start to look like two dots, okay? And the anterior dot is the malleus, and the posterior, and this is sort of where at the level of the neck of the malleus, and we're getting part of, and we're getting into the junction between the epitympanum and the mesotympanum. And then as you go a little more inferior, they're more horizontal and here we're at the level of the manubrium of the malleus, and we're still at the long process of the incus, okay? So we're in the main part of the mesotympanum here. Now, when you're following the malleus anteriorly and the incus posteriorly, once you get to the stapes, you should make note of the long process of the incus. You should always be able to see it at least one slice below the incudostapedial joint to make sure that there's no bony erosion from cholesteatoma or resorption from chronic inflammation. So the tip of the long process of the incus is the only part of the ossicles that can be missing just from chronic inflammation, not because of what happens from what we call hyperemic resorption, where chronic inflammation and chronic hyperemia causes resorption of the bone of the tip of the long process of the incus because it's very well vascularized. And so even without cholesteatoma, you can lose like the calcium and the bone part of that tip of the long process of the incus and just get a fibrous band between the incus and the stapes. And if that happens, you're going to have conductive hearing loss, because if you don't have bone, if you just have a fibrous band, you're not going to be able to transmit those sound waves, and so they'll get conductive hearing loss. So you always make sure you can see that tip of the long process at least one slice below the incudostapedial joint, assuming that you're using very thin slices, which we consider less than 1 millimeter. Ours we reformat at 0.5 millimeters. All right, and so this is just laying it out again. This is that post-shell view. You always want to see that tip of the long process of the incus below the incudostapedial joint, which is actually up here, okay? Because if this is fibrous, you don't get sound conduction. All right, so now we want to talk about the fenestra, which is just a word that means window, essentially. So the oval and round windows are very important structures to scrutinize in the setting of conductive hearing loss, especially. So the stapes foot plate is at the oval window, and you should always make sure that the anterior margin of that oval window has a gizmo. So we want normal bone. It's not too lucent, and you don't have too much bone. Foot plate, okay? The round window is at the base of the basal turn of the cochlea, and it's often overlooked. But if you have obliteration of the round window, which can also occur with otosclerosis, you can also get conductive round window, because effectively what happens with the sound is it vibrates at the foot plate here and it goes up all the way to the apex of the cochlea. The sound waves transduce all the way to the apex of the cochlea, which is where you have a communication between the scala distale and scala tympani, two of the spaces in the cochlea, and then they vibrates all the way down to the base of the cochlea and vibrates at the round window. And if you don't have normal vibration both at the foot plate, the oval window, and the round window, then you lose sound energy, okay? All right, so let's talk about Prusak space, because I'm sure you've all heard of it. So it's this small lateral recess between the scutum and the pars flaccida of the tympanic membrane. And inferiorly, you have the neck of the malleus. And so a lot of people will think that Prusak space is the whole lateral part of the epitympanum here. All right, but it's actually just this very tiny space here. All right, and it's bounded superiorly by this lateral malleal ligament, which you can see here on both the histology and on CT. So the Prusak space is just where this arrow is. It's just this tiny space here. It's not the whole lateral part of the epitympanum. All right, so it's basically bounded by the pars flaccida of the TM, the neck of the malleus here, and this lateral malleal ligament superiorly, and then the scutum where they attach. All right, so that's Prusak space. And the reason we care about Prusak space is because the pars flaccida in acquired cholesteatoma, which is the majority of cholesteatoma you're going to see, it usually starts at this pars flaccida here and then erodes into the Prusak space and the lateral epitympanum, okay? There are 4 ligaments of the ossicles, okay? You have anterior, lateral, and superior malleal ligaments, and then the posterior incudal ligament. You may also see in the text superior incudal ligament that has been described, but it's really just a fold of mucosa that contains vessels and no collagen. You might see these ligaments at CT imaging, especially really high resolution imaging as we're getting into photon counting, but more often than not, do well, and then you have to worry about like ossification, sclerosis, and ossicular fixation. Oh, there's something in the chat. Am I missing something? Oh, no. Okay. In that same histologic image, you can also see the tendon of the tensor tympani, which is right here, okay, attaching to the neck of the malleus. The tensor tympani is one of the two muscles and tendons in the middle ear, and it's innervated by V3. And what it does is it acts to dampen sound, including when you chew or when you speak, right? So there's a reason that you don't hear yourself in your head or hear yourself chewing really loudly. And the tensor tympani helps to dampen sound when you're doing that, okay? So now let's talk a little bit more about the tensor tympani because there's some important surgical anatomy here. So the tympanic orifice of the eustachian tube and the orifice for the semicanal of the tensor tympani are located along the superior aspect of the anterior wall of the middle ear cavity, right? So you have tensor tympani here and eustachian tube here, right? And your carotid is here. These channels kind of lie one above the other and extend anteriorly and inferiorly between the squamous and petrous portions of the temporal bone towards the nasopharynx. The tensor tympani is a more superior structure and is smaller than the eustachian tube, which is here. Here's the tensor tympani, this is coronal, and here's your eustachian tube, and here's your carotid. And the bony structure separating these two is the semicanal of the tensor tympani, okay? This is the semicanal, and this bone is that cochleariform process, like we talked about before, all right? And so these are important because this is your communication between the middle ear and the nasopharynx, all right? The surgeons care about the cochleariform process because for them, it's a landmark for the tympanic segment of the facial nerve canal, all right? If you go, so here we are at the level of the cochleariform process, right? And here's that tensor tympani. And then if you go one slice up, this is the tympanic segment of the facial nerve. There's that cog and that anterior epitympanic recess. And you can see here on the coronal, here's your tympanic segment of your facial nerve canal. Here's that little piece of bone, the cochleariform process, and that tensor tympani. So because they can't see the way we can as we're slicing through, when they go in through a microscopic approach to the middle ear, they need to know where the facial nerve canal is so they don't get into it or to see if it's eroded. And so that cochleariform process is a landmark for them. Here we can see the other muscle and tendon in the middle ear, the stapedius, which is innervated by the facial nerve, cranial nerve 7. It also dampens sound, particularly of your own voice. So there's this piece of bone called the pyramidal eminence. It's a prominence located along the posterior wall of the mesotympanum, and the origin and belly of the stapedius are within that pyramidal eminence. And then there's this small aperture where the stapedius tendon is transmitted and goes up to that neck of the stapes, all right? And so here's a cone beam CT where you can see the pyramidal eminence here and that little aperture where the tendon comes out, and you won't see the tendon, but it's basically coming out the apex here and going towards the stapes, all right? The pyramidal eminence is one of 3 important structures along the posterior wall that from medial to lateral are the sinus tympani here, sinus tympani, recess, which is the most lateral of those 3. And that's an important surgical marker for the location of the mastoid segment of the facial nerve. Again, the surgeons really care about the facial nerve when they're in the middle ear. And so they have to use these external or these bony landmarks for where the facial nerve is running. Okay. And so that's the facial recess. And so when you're dictating about, especially in a cholesteatoma case, it's really important to say if these spaces are opacified, because if there's cholesteatoma in the sinus tympani, that is a relative blind spot to the surgeon when they're coming in with a traditional microscopic approach using a microscope to the middle ear. The newer endoscopic approaches, they have a little bit more access to the sinus tympani, but they will not be able to get into this with your typical microscopic approaches to the middle ear. So you need to tell them if the sinus tympani is potentially involved by cholesteatoma. Okay. This is the appearance of the posterior recesses on coronal CT, which can be difficult to find. But if you look for the round window niche, which is at the base of the basal turn of the cochlea, and then move laterally. In this one, we're on the left side. This is medial and this is lateral. So here's the basal turn of the cochlea. Here's the round window niche, and just lateral to that is the sinus tympani. Here's your pyramidal eminence, and then your facial nerve recess is just lateral to that, and your facial nerve is right above it. There is a small bony ridge that separates, or the sort of the inferior margin of the entrance into the sinus tympani, separating the sinus from the round window niche. And this small bony ridge is called the subiculum, okay, which again was something I was seeing in text, and I was like, what the heck is a subiculum? For us, it's not something you're going to dictate, but it is an important surgical landmark, okay? So if you come across it, essentially it's at the entrance to the sinus tympani. Lastly, just to finish up the middle ear cavity, the hypotympanum is kind of variable in size. It's inferior medial to that piece of bone where you have the inferior attachment of the tympanic membrane and the base of the cochlear eminence here. And so it's usually just air filled. There's usually nothing in it, but and it's usually smaller than the rest of the middle ear cavity, but that's the hypotympanum. All right, so posterior to the middle ear is the mastoid, right? And the mastoid contains multiple pneumatized air cells. It's the largest air-filled space. The largest air-filled space is called the mastoid antrum, right? So room, kind of like the maxillary antrum. It's just the biggest air-filled space in the mastoid. And the additus ad antrum is the large channel that connects the posterior epitympanum to the mastoid. So as we scroll down, here we come down through the mastoid. So the largest air-filled space, this is the mastoid antrum. And as you come down towards the middle ear, now we're starting to see the ossicles. We're in the epitympanum, right? We're getting that ice cream cone look. There's your antrum, and there's your additus ad antrum. So again, that's just the passage or the communication between the epitympanum and the mastoid antrum. All right. Now we're going to go through the intertemporal part of the facial nerve. And so the facial nerve describes a really complex course through the temporal bone. At the fundus or apex of the lateral apex of the internal auditory canal, the facial nerve enters the bony facial nerve canal. And the first portion of the canal is the labyrinthine segment, which is located just superior to the junction of the cochlea and vestibule. And then it curves anteriorly. Sorry, let me go back. Here's your labyrinthine segment here, right? So here's your fundus of the IAC. Here's your labyrinthine segment. It's short. It curves towards this sharp turn, which is called the anterior geno, or anterior, geno means knee, right? Like it's a sharp 90-degree turn of the facial nerve canal. And in this region is the geniculate ganglion, all right? The geniculate ganglion is only really a small portion of the nerve, and it's in this location. It's not like this is all facial nerve. You can't really see the geniculate ganglion, but it's in it, okay? And then it takes a sharp turn posteriorly, forming the tympanic segment of the facial nerve. And it's called tympanic, right, because it's opposite the tympanic cavity or mesotympanum, all right? Let's see if we can see it as it goes off. At the geno, you have this little gap in the bone where the greater superficial patae, and the reason we care about that is because this is a point where, and eventually the greater superficial petrosal nerve joins the inferior petrosal nerve to form the vidian nerve. And as we get into more advanced temporal bone and skull-based imaging, we're going to care about that because that's of head and neck cancer. All right, so then the canal courses posteriorly, okay, along the tympanic cavity, and it goes over the top of the stapes and the oval window, all right, and continues all the way posteriorly until it takes another really sharp 90-degree turn and heads inferiorly through the mastoid. That's the mastoid segment of the facial nerve here. So we have a sharp turn where it stops being horizontal, right? So it's completely horizontal here, takes a turn and becomes, essentially we're seeing it in cross-section now, and that's the mastoid segment of the facial nerve, okay? And then as you go all the way down to the bottom, it exits out the mastoid at a foramen called the stylomastoid foramen. So here we still have the mastoid segment. It's really long. It's heading down inferiorly. We keep going. It widens out. And here we're at the stylomastoid foramen. And that's where the facial nerve exits the temporal bone, exits that bony canal, and goes into the parotid. All right. This is just a histologic segment sort of showing that. Here's your facial nerve. And this is a little nerve called the chorda tympani, which is a recurrent nerve that comes off. off the facial nerve in the mastoid segment and then ascend taste fibers. And so if this nerve, it then travels into the tympanic cavity just behind the tympanic membrane. The ENTs are very careful to try to not sacrifice this when they're doing surgery, because the patient can have changes in taste afterwards. What the otologists tell me is that if you have chronic inflammation in the ear and cholesteatoma and the nerve has already been involved by chronic inflammation, and the chorda tympani is kind of part of that cholesteatoma and gets severed, that doesn't really matter as much in the setting of chronic inflammation. Like, they won't usually have changes in taste because the nerve has probably been dysfunctional for a while. But if you're going into the middle ear for a different reason and the chorda tympani has been completely involved by disease and you sever it, or it gets injured during surgery, then the patient will wake up and have a change in taste. And that will go away over time, but they don't really like to do that, although I do think they tend to consent patients for it. All right, here's a histologic segment of that facial hiatus, right? Here's your that sharp turn of your anterior genu, the geniculate, right? Here it's coming out labyrinthine segment. Here's your geniculate segment. Here's your tympanic segment. And there's that facial hiatus where the greater superficial petrosal nerve comes off. On coronal images, what we're going to see is from anterior to posterior. We first see the anterior genu, so that geniculate segment there, and then we'll see the labyrinthine segment medially and the tympanic segment laterally. And when they split, you can see the cochlea here. It's kind of like a little snail shell, and then you have like two little eyes, right? So if this is your snail and your two little eyes, the medial one is your labyrinthine segment, and the lateral one is your tympanic segment, okay? And then as you come back here, now we're getting towards the IAC. Here's labyrinthine, here's tympanic. And then your tympanic, your facial nerve, is right above the semicircular canal. All right. So when you have your little, people think this looks like a duck bill, right? A duck head and a duck bill. Right under that duck's beak is going to be, and as you come back on the coronal, it takes that sharp turn. It's no longer in cross section, now mastoid segment, as it heads straight down parotid. All right. This actually is the chorda tympani coming off and heading back up towards the tympanic segment of the facial nerve canal. Here it is. Here's that tiny little chorda tympani. You don't typically need to worry about this, but just so you know what it looks like, it goes back up. It's a recurrent nerve. It comes off a little bit more inferiorly of the facial nerve and then heads back up towards the tympanic cavity. All right, there it is there on the opposite side. That's the chorda tympani. All right, so on MRI, the intertemporal segments of the facial nerve can be more difficult to identify. But from your knowledge of CT, you can find it. So here we see the labyrinthine and geniculate and anterior tympanic segments of the facial nerve. All right, it's got that sharp turn. Here's that facial hiatus, and that greater superficial petrosal nerve is going to come out here. All right, on the coronal, it can be harder to see, but here's your cochlea, your snail, and then the two eyes, right? So you got your labyrinthine and tympanic segments there. Here on the axial, here's if you're at the level of the cochlea and the vestibule, it's this long segment here heading back from the geniculate. On the coronal, you want to look for that duck's beak of the lateral semicircular canal, and the facial nerve will be right underneath it. All right, and then your mastoid segment, it's going to be in cross section on axial, and this is the long segment on coronal and heading out into the fat at the stylomastoid foramen and into the parotid here. All right, so we're just going to wrap up with talking about the inner ear and the petrous apex. We'll see how far we get. So you have a bony labyrinth and a membranous labyrinth, okay? And the bony labyrinth is your cochlea, vestibule, and semicircular canals, and then your membranous labyrinth contains those endolymphatic structures, the cochlea, the scala media, the vestibule, which also contains the utricle and saccule, which we can't typically see, although with some newer MRI imaging for many years, we can sort of see it. And then within the semicircular canals, you have endolymphatic semicircular ducts, and then you have the endolymphatic duct and sac. All right. So the bony labyrinth, there's perilymph, and then inside that, there's the endolymph within the endolymphatic structures. All right. So we can see this very nicely on histopathology. So within the cochlea, as I mentioned earlier, you have two big spaces, the scala vestibuli and the scala tympani. And the way I remember which one is which is tympani means it's like drum, right? And so it's flat on the top and it's the bottom. So this is shaped like a tympani drum. That's the scala tympani. And then the scala vestibuli is the top part, okay? And essentially what happens, as I mentioned, is at the oval window, the sound waves vibrate and they transmit sound through the scala vestibuli all the way up to the apex of the cochlea. And then there's a little communication at the top. The scala vestibuli and scala tympani are in continuity at the apex of the cochlea, which is called the helicotrema. And then they vibrate all the way back down to the basal turn of the cochlea along the scala tympani to the round window. In between the scala vestibuli and scala tympani, you have the scala media, which we, again, can't really resolve on imaging. But this is the endolymphatic space. So there's perilymph in both of these big spaces, and then there's endolymph within this small space here. And these are the hair cells along this basal membrane here within the scala media, and this is where the sound is transduced to the nerve. These hair cells vibrate, and that's how we transduce sound waves into neuronal signals to the cochlear nerve, all right? Here at the center is your cranial nerve 8 within the center of the cochlea. Okay, these are the ganglia in here, and they send out their little nerves along the hair cells here. This center part of the cochlea is called the medulus. All right, here's another section just showing that, right? Your nerve coming in through the IAC. This is your big cochlear nerve coming into the center at your medulus, and the nerves come out along the basal membrane here. And this is where the sound transduction from, sound waves to neuronal signaling happens. All right. So here's your cochlea on CT. You've got 2.5 turns, apex, middle turn, and basal turn. And then that center bony spiral that we talked about, that's called the medulus. All right. You always want to look for this lateral attachment of bone here, this little notch between the middle and basal turns. Because if this is gone, if this is kind of bulbous or not there, then we start to think of incomplete partition or underdevelopment of the cochlea, and that gets into cochlear anomalies. All right. We can see the internal structure of the cochlea a little bit better at MRI using this high resolution T2 weighted imaging. So we can the scala vestibuli and the scala the cochlear nerve aperture or cochlear facet into them for say sensory neural hearing loss, and you don't have a case of cochlear nerve aplasia. At CT, although this is a cone beam CT, and again with photon counting, we might start to get a little bit better. We start to see, but usually we can't resolve this at CT. All right. The vestibule is the most central structure of the bony labyrinth, and it communicates anteriorly with the cochlea and posteriorly with the semicircular canals. This vestibule is a relatively ovoid, large space. Okay, mostly contains perilymph. The utricle and saccule are in here. Again, you can't see them. Those are the endolymphatic spaces, but they're normal patient. All right. The vestibule is the most central structure of the bony labyrinth. Again, like you're going to see it's the close. When you're looking at it on MRI, it's going to be T2 hyper intense. Again, you're not really going to be able to resolve that utricle and saccule. And it's very close to the fundus or apex of the IAC. The sensory organs of the vestibular labyrinth are located within the saccule and UG. Okay, and it's right. And so having a normal saccule and utricle and a normal proportion between perilymph and endolymph is very important. And when you start to get something called endolymphatic hydrops, where the saccule and utricle and the endolymphatic spaces within the cochlea and semicircular canals get hydrops or too big, that's when you start to get chronic vertigo with many ears. All right. This is just another histopathology slide showing the utricle and saccule and showing that you have mostly perilymph within those semicircular. They each describe approximately 2/3 of a circle, and they're oriented at right angles to each other. All right. And the medial arcs of the posterior and superior semicircular canals are actually all right. So these are some 3D renderings here of the semicircular canals. On CT, we like in coronal, as I said, that duck's beak appearance is right over the facial nerve canal. So that's the lateral canal. This is your superior canal. In the axial plane, we reformat ours along the lateral canal. So we see it as a complete circle canal, which you can use as a sort of internal control for how big the vestibular aqueduct should be. So here's your posterior canal. All right. This is a nice cone beam CT again, just showing the entire superior canal in parallel. So this is what's called the post-shell view. And then the Stenber's view is down the barrel of the superior semicircular canal. We use these when we're trying to screen, or when a patient is coming in and they're questioning superior semicircular canal dehiscence, which is another entity that can result in conductive hearing loss. It can also result in sound-induced vertigo, something called Tullio's phenomenon. And so we use these reformats called the Stenber's and Post-shell. Not important to memorize them, but essentially down the barrel of the superior canal and parallel to the superior canal to look for areas of bony dehiscence up here, which can result in, again, vertigo and conductive hearing loss. In the center here, you have two little dots. This is a normal structure. It's called the subarcuate artery passing through the ring of the superior canal. Sometimes when you're looking at this or scrolling through in the other planes, people can think that they're a fracture. This is a normal structure. It's called the subarcuate artery and vein. All right, it's right there. That is not a fracture. That's a normal structure. All right. And then posteriorly, we always want to look at the vestibular aqueduct because, again, the vestibular aqueduct can be enlarged in some congenital anomalies. The aqueduct contains the endolymphatic duct and sac. And again, we like to use the posterior canal as an internal control for how big the vestibular aqueduct could be. There are a lot of publications about size criteria for how big the vestibular aqueduct can be, including something called the Cincinnati criteria, which you can look up. But essentially, a good internal control is just if the vestibular aqueduct is not bigger in caliber than the posterior canal, then you're good. All right. The post-shell images can be really nice for looking at the entire course of the vestibular aqueduct. And there's a paper out of Mass Eye and Ear actually saying that you should probably only be measuring the canal on post-shell imaging because that's really, you're not cutting through it in an oblique way. You're really cutting through it directly like perpendicular, so you can measure the circumference more accurately, but you can see it coming off the vestibule here and heading down. All right. I'm going to run over on time, so I'm going to skip through some of these, which are a little more advanced anyway, about the endolymphatic duct and cochlear aqueduct, which is not as important for you to know. Lastly, I just wanted to show these nerves, right? So when we're on MRI, we're looking for the nerves that come off the lateral part of the pons and go into the IEC. So it's the 7th and 8th nerves, right? And so the 7th nerve, the facial nerve is going to be anterior and superior. And then as you go a little more inferior, you're going to see the cochlear nerve. And then posteriorly, you have the superior and inferior vestibular nerves, right? And so when you look at them in a sagittal oblique, anteriorly and superiorly, you see the facial nerve, anteriorly and inferiorly, you see the cochlear nerve, and then you see this big trunk of the superior and inferior vestibular nerves here posteriorly. And so when we're looking at congenital hearing loss, you always want to make sure that the cochlear nerve is as big in caliber as the facial nerve to rule out cochlear nerve hypoplasia. All right. These are some bony structures that are not as important for you to know. The petrous apex, the one thing I want to say about it is that asymmetry is very common. They do not have to be symmetric, and a lot of times you have pneumatization on one side and normal fatty marrow on the other side. So don't call this a mass or a lesion. That's just normal fatty marrow. And here we just have pneumatized air cells. So it is pretty common to have asymmetry of the petrous apices. All right. Here it is on FAT-SAT. You can see that normal fatty marrow just drops out. Okay, so that's not a lesion. Here we have pneumatized air cells on the left and just fatty marrow on the right. If you do have air cells that are pneumatized here, you can get disease in here. You can get infection in here and petrous apicitis. Usually it comes out from the outside in, right? You get a middle ear infection and then it involves the petrous apex. But you can only get petrous apicitis if you have pneumatized air cells in the first place. All right. These are some canals we're going to skip because it's a little more advanced and not as important to know, and we are short on time. All right, so in summary, all right, your imaging checklist, you should start from the outside in when you're doing CT, from the external ear all all the way to the petrous apex. Go through your mastoid and middle ear, look at the ossicles, look at the entire course of the intertemporal facial nerve, make sure that you don't have an inner ear anomaly, that all the turns of the cochlea are there, that the vestibular aqueduct is not enlarged. And then, look at your petrous apex for any opacified air cells or erosion. When you're on MRI, we go from that inside out. We look at those nerves, petrous apex marrow, and then go out. You're not going to see the bony structures. You're not going to see the ossicles on your MRI. So we really focus on the inside with the MRI. And again, this is just a reminder that this website is available. You can download PDFs. You can look at CT with histopathology side by side in both diseased and normal temporal bones. And that's it. Any questions? I know that was a lot of information.
No. Thank you, Hillary.
Yeah, no problems. I gotta go do some ultrasound. But anyway, thank you guys so much. Feel free to email me if you do have questions. I can send out a PDF of these slides if it would be helpful. Yeah. And I'm gonna stop share. Yeah. So thank you guys. Have a great rest of your day. Just making sure there's no, yeah, nothing in the chat. Okay. Bye guys.